Hello, I'm Kevin Fernando, a GP working near Edinburgh in Scotland and content advisor for Medscape Global and UK. Welcome to our podcast, Medical Mentor, a bite-sized regular chat for all of us working in primary care. Podcasts will cover hot topics, practice pearls and hacks, as well as pitfalls to avoid, helping make our lives a little bit easier in primary care, but ultimately to help improve the lives of our patients. In this podcast, I'm going to talk about unexplained high platelet counts or thrombocytosis and the risk of cancer in primary care. So let's start with a typical case we all might see in primary care. Louisa is a 47-year-old lady and chief financial officer for a tech startup company. She presents to us in primary care feeling tired all the time. Very common presentation in primary care with associated reduced appetite. Past medical history includes irritable bowel syndrome, and she's an ex-smoker. Systemic inquiry is unremarkable. Specifically, there's no history of weight loss. Louise is not prescribed any medication and uses over-the-counter remedies for her irritable bowel syndrome. Examination is also unremarkable. Bloods were checked, which were all reassuring except a platelet count of 612. Usual normal range about 150 to 450. So what do we do next? Do we refer for an urgent chest x-ray to exclude lung cancer? Do we check a Q-fit to identify any occult bleeding in her stool? Or do we refer for a routine upper gastrointestinal endoscopy or pelvic ultrasound scan to exclude any upper gastrointestinal or endometrial malignancy? Or do we simply repeat our bloods? And if so, do we repeat them routinely or urgently? And indeed, which bloods should we recheck? So Louisa has an unexplained thrombocytosis. How do we manage this in primary care? Now, thrombocytosis is generally defined as a raised platelet count over 450. Importantly, thrombocytosis is a common incidental finding in around 2% of those aged over 40 years of age attending primary care. And reassuringly, 80 to 90% of thrombocytosis is reactive, secondary to acute blood loss, infection, or inflammation. And the majority of cases resolve within 3 months. So why the concern with Louisa then? Well, although most cases are reactive, clinical guidance, for example, NICE suspected cancer guidance in the UK and Scottish suspected cancer guidance in Scotland, remind us that unexplained thrombocytosis is a risk marker for some solid tumor malignancies. Previous studies have demonstrated that unexplained thrombocytosis is associated with a 1-year cancer incidence of 11.6% in males and 6.2% in females, well exceeding the standard 3% threshold warranting investigation for underlying malignancy. However, thrombocytosis should not be used as a standalone diagnostic or screening test for cancer, or indeed to rule out cancer. Instead, unexplained thrombocytosis should prompt us to think cancer. The Scottish suspected cancer referral guidelines include thrombocytosis in the investigation criteria for what they call the Lego C cancers. L for lung, E for endometrial, G for gastric, O for esophageal, and C for colorectal, which is a useful reminder for us all. So what further history, examination, and investigations might we consider in primary care if we identify an unexplained high platelet count? Well, as always, we should use our clinical judgment and trust our clinical acumen. We should consider all the possible underlying causes: infection, inflammation, blood loss, including menstrual blood loss in women, myeloproliferative disorders such as polycythemia rubra vera, chronic myeloid leukemia, and essential thrombocythemia, as well as, of course, underlying malignancy. If a likely underlying reversible cause is present, for example, a recent lower respiratory tract infection, simply repeating the full blood count in 4 to 6 weeks is quite appropriate to see if the thrombocytosis has resolved. Remember, 80 to 90% of cases are reactive thrombocytosis, and most cases resolve within 3 months. If thrombocytosis is unexplained or not resolving, consider checking a ferritin level to exclude iron deficiency. Consider checking a CRP to exclude any inflammation. And also consider checking a blood film to exclude any hematological disorders. In addition, of course, to more detailed history taking and examination to elicit any red flags. We can also consider what we call a JAK2 gene mutation test, if it is available to you locally, or a hematology referral if we suspect a myeloproliferative disorder. JAK2 is a genetic mutation that may be present in people with essential thrombocythemia and can indicate a diagnosis of polycythemia rubra vera. Subsequent to this, and again using our clinical judgment, we then need to exclude the Lego C cancers. Consider an urgent chest x-ray to exclude lung cancer, or pelvic ultrasound scan in women to exclude endometrial cancer. Also, we should consider upper gastrointestinal endoscopy, particularly in those individuals who have associated upper gastrointestinal symptoms and or weight loss. And finally, consider a Q-FIT test to identify any occult bleeding in the stool, again if it's available to you, or certainly if not, urgent lower gastrointestinal investigations to exclude colorectal cancer. Alongside these possible investigations, as always, we should safety net appropriately within agreed timeframes and check for resolution of the thrombocytosis according to the condition being suspected. Remember, most cases resolve within 3 months. So, returning to Louisa, what did I do? After seeing a platelet count of 600, I subsequently telephoned her and re-explored her history, which yielded nil else of note. Specifically, there was no history of unexplained weight loss, no history of upper or lower gastrointestinal symptoms, certainly nothing significantly different from our usual irritable bowel syndrome symptoms. There were also no respiratory or genitourinary symptoms of note. I did arrange for Louisa to undergo a chest x-ray over the next few days though, as she was an ex-smoker, and this was subsequently reported as normal. Now, I appreciate chest x-rays have poor sensitivity for detecting lung cancer, as highlighted in a number of recent papers, but it was mutually agreed with Louisa that we would simply repeat her blood tests in around 6 weeks. And as well as repeating the full blood count, I arranged to check a ferritin, CRP, and a blood film, and then I was planning to reassess her clinically in person. These bloods and my subsequent clinical review were reassuring, and in fact, her platelet count had normalized after that 6 weeks had elapsed. Her thrombocytosis had resolved. So I didn't arrange any further follow-up for her, but I did give her the usual safety netting advice to re-present to me or one of my colleagues if she does develop any worrying symptoms or signs. Now, I appreciate these scenarios are not always this straightforward, but what I wanted to outline is what investigations and referrals we may need to consider in primary care if we encounter an unexplained high platelet count. So a couple of quality improvement activities for us all to consider in primary care. Consider as a team how we would respond to an incidental finding of thrombocytosis on a full blood count. And also consider what are our safety netting options for those found to have raised platelet counts but no other symptoms or risk factors for underlying malignancy. Finally, I've produced a Medscape UK primary care hack or clinical aid memoir on managing unexplained thrombocytosis and associated cancer risk in primary care for all healthcare professionals working in primary care. This can be found at medscape-uk.co/hacks. I hope you find this resource helpful. So thank you all for listening. I hope you found this podcast helpful. Please do listen to our future Medical Mentor podcast, which will be available on all major platforms. Follow me on X, formerly Twitter, at Dr. Kevin Fernando, or email me on kfernando@webmd.net if you have any questions, comments, or ideas for future podcasts. Thank you again for listening.